Yeah, good morning, everybody. And thank you, Paulius, for inviting me to this conference. I guess it's the largest audience I ever had. So I heard it's more than 1,000 people registered. So very, very nice. And I hope I will get my message through. Special greetings to the interpreter. I hope I give you not too much of a hard time with my Austrian English. So today I will talk about the suicide risk among LGBT plus individuals. I will start with some definitions, and then I will talk about the scope of the problem. I will give then explanatory models and an outlook what we can do in suicide prevention for this special population. So let's start with some definitions. LGBT plus, what is the acronym standing for? It stands for lesbian, gay, bisexual, trans, and the plus is opens up the space for other sexual gender minorities. The rainbow flag is a very nice and positive symbol for all those diverse expressions of sexuality and gender identities. So we need to have a further look at the definitions. It's not obvious to everybody from my experience. So let's start with the sexual minorities, the largest group I will talk about today. Here it's about sexuality and sexual orientation. And here you have to take a look at the dimensions of sexual orientation. So people are sexual minorities because they identify as sexual minorities, such as gay, lesbian, bisexual, and so on, or because of their sexual behavior, men who have sex with men or women who have sex with women. And then finally, and perhaps the most important dimension, the psychological dimension, which is to whom are people sexually attracted to, or which sexual fantasies are going on in their minds. It is important to keep in mind that these dimensions are correlated for most people, but far from perfectly correlated. So it's known, for example, from a study from New York, where the majority of men who had sex with men did identify as heterosexual. Overall, a common characteristics for sexual minorities is that they are some kind of other than exclusively heterosexual. However, these definitions have a limitation because they assume a binary definition of gender. So imagine how would you classify a transgender man who has sex with a woman? Is he or she heterosexual or gay? So there's an alternative way of definition. So based on the attraction towards to whom you are attracted to, if you are attracted to women or feminine characteristics, masculine or both, then it would be gynophilic, androphilic, or pansexual. The next important minority I will talk about today are trans people, and here it's not about sexuality, here it's about gender identity and gender expression. A current definition of trans is that is a gender identity that's different from sex assigned at birth, and also people who are gender non-conforming, and also cross-dressers. These are people who have an appearance different from their biological sex by means of clothes. Finally, a group that's often ignored are interpeople, and here it's about biological sex. And how can you define biological sex? You can define it, and that's not too obvious for many, on several levels: on the chromosomal level, on the genital level, on the gonadal level, or on the hormonal level. And interpeople do not have the typical or the stereotypical female or male characteristics. Some interpeople have only one X chromosome or two X chromosomes. They have ambiguous genitals or a mixture on the gonadal level. They have a mixture of ovaries and testes, or on the hormonal level, for example, the androgen insensitivity syndrome. You can see women here with this variation of sex. They have the androgen insensitivity syndrome. It's a genetic variation where they don't respond to male typical hormones in their development. They are chromosomal males, but develop a female typical body. Sorry. So the common characteristics of interpeople, they do not have stereotypical female or male biological sex. Or to put it this way, nature has more to offer than two sexes. In medicine, it's still called disorders of sex development, but the interactivists prefer to use the expression diversity or differences of sex development. A dark spot in the medical history are the genital surgeries for interpeople. So it was often the case, but it's still the case that if newborns have ambiguous genitals, that they are often experience surgery to make them look female typical, and that does not often does not correspond to the later female gender identity. So let's move from this definitions to the scope of the problem. What do we know about the suicide risk among LGBT plus people? And before 1995, it was a difficult picture, because most studies, most samples were drawn only from the gay communities, and there was the critical question: how representative are these studies to the general LGBT plus community population? Sorry. However, in the last 25 years, we experienced an impressive innovation in research methods. Now we have a large variety of representative population, random-based samples that are representative of the LGBT plus population. We have studies that use a matched control group design, so where a gay or lesbian or bisexual sibling is compared to the heterosexual sibling, or same for twins. And we have prospective studies where people are followed up even from their birth, so a lot of improvement. However, we have to acknowledge that methodological challenges always remain, more or less. This is because LGBT plus people are kind of a hidden population. You have to ask people to know about their sexual or gender identity. And another challenge is that both LGBT plus status identities and suicides are rare events. So if you want to come up with a precise estimation of the suicide risk among LGBT plus people, you really need very, very large samples. Pierre Tremblay, a colleague from Canada who unfortunately died a few years ago, and he was a great mentor. I learned so much from him. And me, we did a systematic review based on PubMed studies and on population-based studies. We could retrieve 199 such studies, and we published this in 2015. So we tried to come to an overall picture, and we looked at the suicides. Only few studies. Most studies were about suicide attempts, lifetime or past year suicide attempts. And what we found is that in nearly all studies, compared to heterosexuals, LGBT individuals had an increased risk for having attempted suicide. In most studies, this was a large difference. The odds ratio was more than 3.5, which means that the suicide risk was more than threefold increased for LGBT individuals compared to heterosexual individuals. We found this increased risk also in more recent studies, in higher quality studies across the regions. Most studies are from the United States or from Canada, Australia, and Europe. Very few studies from other regions. We found the increased risk for both lesbian and bisexual women, and also for gay and bisexual men. We also found the increased risk not only for adolescents, but also for adults. So it's not just a problem for the adolescent, for the very young LGBT people, but studies found a second peak of risk in the mid-30s. We found the increased risk always relative to heterosexuals, for bisexual people, homosexual people, and also all other subgroups. But there is some kind of consistency that the bisexual identified people or bisexually behaving people have the highest risk within the sexual minority groups. We find the increased risk for all dimensions of sexual orientation and for lifetime and past year suicide attempts. So the overall picture is quite consistent and the data is quite robust. When we want to see if there's also an increased risk for suicide deaths, then it's really methodologically challenging. You cannot ask people who died by suicide about the LGBT plus status. So one way to overcome the difficulty is to use the psychological autopsy method. Here you ask the family members or the friends and relatives of people who died by suicide if the deceased was LGBT identified or sexual or gender minority member. And here, contrary to previous claims, in a study that was published 2013, we found that LGBT people are indeed overrepresented among the suicide victims. However, validity issues remain because you don't really know how many of the friends and relatives actually knew about the sexual orientation. Many people may have not disclosed this. So another method that's perhaps better or more valid is to link registers. And here Denmark and Sweden had the excellent opportunity to link the register of marriages to the register of deaths. And in Denmark and Sweden, which are quite liberal countries, it's been possible for a long time now that two men and two women can marry. And so you can compare the suicide risk for those who are in a same-sex marriage compared to the risk for heterosexually married people. And here you can see that the risk is increased, the risk for dying by suicide is increased for people who are in same-sex marriages compared to heterosexual marriages. And the risk is fortunately decreasing somewhat over the time, but it's still increased. Sorry, I hope it's not COVID. There are biases in this type of methods too, because LGBT people do marriage to far less likely married compared to heterosexual people, and it's also known that people who are married have a better mental health and a lower suicide risk. And plus, Denmark and Sweden are liberal countries for LGBT plus issues, so we can infer that these results are actually underestimations of the true problem of suicides among LGBT plus people. Another strategy is to link surveys, population-based large surveys, the participants who take part in these surveys to the death register. And in the meantime, we have 3 such surveys existing all from the United States, and we published that recently last year. And here you can see that there's an elevated risk for sexual minority women who participated in this survey to die by suicide later on. The risk is increased in 2 studies for sexual minority men. In 1 study, it isn't increased, and the confidence intervals are here very large. So the data here is still inconclusive. So overall, it can be said with quite certainty that the suicide risk for LGBT people is increased, substantially increased. Yes. So let's move to trans people. What is known about the suicide risk of trans people? Here we have far less studies, but then a picture emerges. Most studies, trans people have a higher risk of having attempted suicide than compared to LGBT people or to heterosexual and cisgender people. There are still only few random samples. There are 5 studies that I know of. And in most studies, again, trans people have the the highest risk for having attempted suicide in the lifetime or past year, but not in all studies. In the Espelage study, LGBT people had a higher risk for suicide attempts than compared to trans people. Toomey recently published a study where he took a closer look at the subgroups within the trans people, and he found the largest risk for the female to male trans people, with 51% having attempted suicide once in their lifetime, followed by non-binary identified trans people, male to female trans people, or trans people who are questioning their sexual identity. In several studies, it was found that after receiving affirmative medical interventions, such as hormonal treatment or surgeries, the mental health risk is improving for trans people. However, the risk remains elevated, at least for those trans people who are in medical care contact. And you see here that the suicide risk per 100,000 is increased for people, trans people, for male to female trans people and female to male trans people compared to cisgender men or women. That's data from the Amsterdam cohort study, one of the largest prospective study on trans people. For enter and suicide risk, very quickly, we even have less data, very sparse data, mostly from clinical settings, which is a limitation. And across these studies, it seems that the risk for suicide ideation or suicide attempts is increased for most interconditions. There's one exception: people with the congenital adrenal hyperplasia, who have sometimes ambiguous genitals and who later on lived in the female role, had actually a reduced risk for suicide. It's again data from Sweden, who have excellent register-based data where all people with such interconditions are registered at birth, so you can link this to the death register. An important fact is also that in one study, there was more suicide ideation among those people who experienced gonadectomy, so who had their gonads removed after birth, than compared to those without such gonadectomy. It's an indicator that these involuntary surgeries at birth are harmful. I talked a lot about an increased risk, but it's really important to point out that most LGBT plus people do not attempt suicide. Based on a meta-analysis from Hottis et al., he found that 4% of the heterosexuals have attempted suicide once in the lifetime, and in LGBT people, it's 11% in population-based surveys and 20% in LGBT community surveys. So it has to be said that at least 80 to 89% of LGBT people never attempted suicide. It's really important. It would be so stereotypical to say that all LGBT plus people are suicidal, and it's a completely not true pathologization. Perhaps you would like to know what the COVID pandemic did to LGBT plus people, and the first studies are actually emerging recently. Here, one study from Switzerland, young men in Switzerland who were surveyed before and during the pandemic, and it was actually found that the pandemic had a more negative impact compared to heterosexual young men, at least with respect to depression, sleep quality, or internet sex use. And similar findings were found for in the United States. Here, a national representative studies of adults done in April, May 2020, and it included also retrospective question about the mental health before the pandemic. And for nearly all indicators of mental health, it was found that the impact of the pandemic was more pronounced for LGBT plus people compared to heterosexual people. So how can we explain the increased risk for suicide for LGBT plus people? And it's not just about explanations, but it's also already an outlook what has to be done to prevent the suicides here in this group. Before I give you the theoretical model, I give you the result of a survey from the Human Rights Campaign in 2012, Growing Up LGBT in America. And this study is remarkable because it used an open-ended question that said, what is the most important problem you face in life right now? And for non-LGBT youth identified, for heterosexual or cisgender youth, the age-typical problems emerged. So the number one problem was problems in school with classes, with grades, problems with college or career, and problems related to financial pressures or job. However, for LGBT youth, the number one problem were non-accepting families, school bullying problems, and fear of being out or open. So a striking difference and of course, these LGBT youth have all the additional age-typical problems too. So what we see here is that LGBT youth have very specific stressors that we now take a closer look at. Oh, yeah. Elon Meyer, he tried to integrate stress theories with these special minority stressors that minorities experience, and he set up a model how to explain mental health outcomes amongst the minorities, which can be sexual orientation minorities, but this model also applies to race and ethnicity minorities and to gender minorities. So how does it come from the minority status to negative mental health outcome? Here, a crucial role is minority stress. And one such form of stress is the so-called distal minority stress. These are observable, objectively observable prejudice events, discrimination, or violence, but also proximal minorities stress processes such as these are processes that happen rather within the person, such as expectation of rejection, stress that is associated with concealing one's sexual orientation or gender identity, and internalized homophobia. This is a negative attitude towards your own homosexual, bisexual orientation or transgender identity. Then there are additional general stressors, and all of these stressors don't necessarily lead to a negative mental health outcome. If there is enough coping resources and if there is enough social support, then the negative effects of these stressors can be buffered. And from the social support research, it's known that especially family support is crucial here. And then, of course, characteristics of your minority identity play a role. It makes a difference if you come out, for example, in an urban academic area where being LGBT plus is not a big issue than compared to growing up in a very rural and homophobic region. There are, of course, other explanatory models that I cannot go into detail because of time limitations. I just want to mention it, and you can look up the slides later on. One issue is, can we use these models which were developed for LGBT people also for trans people and inter people? Yes, you can do that because some stressors do overlap. But no, you can't, because trans and inter people face very specific stressors. Trans people, for example, have often the problem to find appropriate healthcare, access to hormonal treatment or access to surgical treatments. And inter people have specific problems because often the family, the parents already know about the inter status, but the inter people themselves only learn it after puberty, for example. So very specific differences. But overall, explanatory models that I outlined so far have been successfully applied to trans and inter people too. So now some data about that these minority stressors are actually impacting mental health of LGBT plus people in a negative way. Here's a very impressive study from Australia. On the left-hand side, you see the regions, the districts of Australia, and a few years ago, there was a voting where people could vote in favor or against same-sex marriages. And on the right-hand side, you see how this is correlated with the mental health of people. And in areas where there were more no voters, where people were against the allowance of same-sex marriages, that the mental health was decreasing the more no voters were in this region. And there was no such impact for heterosexual people. And Mark Katzenbühler, he does excellent studies in this field. He did a related study about the regional homophobia and mortality. He used the General Social Survey data from the United States. It's a very large survey about attitudes. It covers the whole United States, and it also includes questions about the attitudes towards gays and lesbians. So you could create a map of homophobia in the United States. And there were more than 600 sexual minority individuals participating in this study. And what he did, he combined, he looked up how sexual minority individuals who participated in this survey, how early they died. And he really could find that in those least homophobic regions in the United States, sexual minority individuals were living longer than compared to regions with most homophobia. So very striking example of the impact of homophobia on not just suicidality, but also on overall mortality and health. So I skipped some slides. I have to go back. What's the extent of the problem in Lithuania, in Europe? And here you see on the left-hand side, you see a result from a European survey that was done in all European Union member states. And on the left-hand side, you see how frequent LGBT plus people in the European Union experienced harassment in the past 12 months before the survey. And you see that Lithuania ranges on the rather negative side. So 43% of LGBT plus people experience such harassment. And it's no wonder that when you look at the right-hand side here, you see the results for the level of openness about being LGBT plus people. And here Lithuania ranks on the lowest end. 60% of LGBTI people say that they are almost or never open to others with respect to their LGBT plus identity. Yeah, so also we need to look at homophobia not just on the interpersonal level, but also on the structural level. This is called a structural stigma. Here it is about discrimination based on the legal level. Here on this slide, you see sexual orientation laws in the world, and the red countries, the dark red countries are those countries where there is still death penalty for same-sex consensual acts. So you see that it's still deadly to be LGBT in these countries, mostly Arabic countries. The blue countries are those countries where there is largely equality between LGBT plus people and heterosexually or cisgender people. And when you take a closer look at Europe, you will see that we are in a lucky position, or LGBT plus people are in a lucky position to be able to live in Europe. And in most countries, there is equality. In most countries, people can marry to men or to women can marry or can adopt children. For Lithuania, I see in this chart that there are still legal barriers to freedom of expression on sexual orientation and gender identity issues. So perhaps we'll hear more about that in the next talk. How does structural stigma impact mental health? And it does have an impact. Here you see a striking study from Mark Katzenbühler again, and he looked at the impact of the gay marriage ban on the mental health of LGBT people. In the United States, there was the gay marriage ban in 16 countries of the United States. So it was decided that same-sex marriages will not be allowed by constitution. And there was a prospective study done that was accidentally done before and after this gay marriage ban. And here you can see that in those countries where the gay marriage ban was introduced, that in those countries, the percentage of LGBT people with mood disorders was increasing, whereas in countries without this gay marriage ban, the mental health for LGBT people slightly improved. And there was no such impact for heterosexual people. So finally, a word on why do people are homophobic or transphobic? It's to me, it's something that's very irrational. And there are, of course, several social psychology dynamics going on here, such as scapegoating. But one issue is that I think is very important. It is because LGBT plus people are transgressing gender roles or are assumed to transgress these gender roles. So, and we could discuss a whole day about why this is a problem for so many people, why people become hateful when people transgress gender roles. And this is a very important risk factor. Here you see a study from Jörger et al. Published in 2015. It was a very large representative study on adolescents. And these people were not only asked about sexual orientation, but also if they have been bullied because of being gender role non-conforming. And here you can see that this type of bullying happens a lot more often among the LGBT identified adolescents than compared to the heterosexual identified individuals. And strikingly, you see that the suicide attempt risk is far more increased for adolescents who experience bullying because of being gender role non-conforming. And when you make some calculations, then you can see that among all suicide attempters, there are a striking number of 25% who are LGBT identified. And if you look at those who are LGBT identified and or bullied because of being gender non-conforming, then you see that this makes up 70% of all suicide attempts. So it's gender LGBT issues and the associated bullying because of being gender role non-conforming plays an important important factor to explain the suicide risk of adolescents. And one important side note, it's not only a problem for LGBT plus adolescents. In terms of numbers, victims of bullying because of being gender role non-conforming is in fact much higher for those heterosexual people who are bullied this way than compared to actually LGBT people who are bullied because of being gender role non-conforming. So finally, a look at the prevention possibilities. What can be done to prevent the increased risk for suicide among LGBT plus people? And here it's really necessary to think on all sorts of prevention levels. Let's start with the individual levels. It's important to provide tailored services. So for example, helplines such as the Trevor Project in the United States. These are crisis hotlines for suicidal LGBT plus people. And yes, it should be pointed out here that this type of support has been historically provided by LGBT plus organizations all over the world. They were nearly always the first to provide it, support, often voluntarily without financial interests. It's now known that substantial proportion of LGBT plus people would not use other hotlines. It was found out in a study on callers of the Trevor Project hotline. Then, of course, it would be good to have tailored psychotherapies, and these are existing. For example, cognitive behavioral therapies, which are informed by the minority stress models that I have outlined. And John Pachankis, he published excellent work on this. Then everything that's helpful to provide hope is important. You know that hope is an important protective factor for suicide. Hopelessness is, on the other hand, an important risk factor for suicide. And there is the It Gets Better.org project. These are online videos where prominent people, Barack Obama or Joe Biden, for example, they give a message specifically to LGBT plus people to give them hope, to say it will get better and hold on, and it will get better. But also people such as you and me who provide, who describe how they got through a suicidal crisis, and really very touching videos. I recommend to take a look at this project. We also realized it in Austria a few years ago, and perhaps it's an opportunity to implement this project also in Lithuania, or I don't know if it's already happened. And then, of course, a very important prevention necessity is to provide affirmative healthcare for LGBT plus people. How can this be done? Perhaps also in your institution, some ideas. You can start doing education and workshops. But here I recommend to really also look at the organizational aspects. It makes a crucial difference if the head of your department is supporting such workshops or not. In these workshops, it's good to learn about the realities of LGBT plus people. And of course, this can be done by promoting support to LGBT plus role models or to LGBT plus colleagues. It's known from social psychology that the attitudes towards LGBT plus people is most strongly impacted by the fact if you personally know someone who is openly LGBT plus or not. You can enhance visibility by, for example, using the rainbow flag. Rainbow flag is an implicit symbol for LGBT plus people, that they are welcome in your institution. But of course, you can use also more explicit posters. Then please use inclusive language. So what does this mean? Try to avoid heterosexual and cisgender assumptions. So if you make an intake survey for a patient, and the patient, for example, is a man, don't assume when you check the partnership status and he says, yes, he is in a partnership, that his partner is a woman, could also be a man. So try to be open about that. And same for cisgender assumptions. Simply because someone is appearing a male or female typical, it does not mean that the gender identity is in accordance with this appearance. For trans people, it's also necessary, or a very important step, to use appropriate names and pronouns. The name the trans person wants to be called, even before the legal procedures are completed. And also, of course, try to provide a non-binary infrastructure for the rooms or for the washrooms. And of course, it's always good to have organizational policies against LGBT plus discrimination. So these were the suicide prevention efforts on the individual level, but then we have to think on the social level too. So there are attachment-based family therapy approaches. As I already said, support from the family is one of the most important protective factor for LGBT plus young people, and there are specialized therapies for this. There's also the excellent Lead with Love project, which provides videos for people who are struggling with their LGBT plus parents. It's known, and I know this personally, that even very liberal and open-minded parents are struggling when their child come out as LGBT plus. And in these videos that you can also watch for free on the web, there are really very honest and very touching stories about parents who overcame these struggles. And then you can also do prevention in schools. In the United States, there are those gay-straight alliances where LGBT plus people connect with heterosexual or cis people. Or you can also introduce anti-bullying policies in schools, of course. And there are the first studies who actually could show that schools who provide these measures have, in these schools, LGBT plus young people have lower rates of suicidality than compared to schools who do not have these infrastructure. And finally, of course, we have to work and think on the societal level, on the level of the structural stigma. It's important to achieve legal equality. And I would also hope that the religions will become more open towards LGBT plus people. As you sure know, religion is such an important protective factor for suicide. But religious LGBT plus people are often in an identity collapse between their religious identity and their LGBT plus identity, and it's often a challenge to resolve this struggle. And of course, anything that makes the population attitudes towards LGBT plus people is also suicide prevention. There, yes, I'm through it. Thank you very much for your attention, and perhaps we can discuss a little.
Thank you, Martin, for very informative presentation. We have several questions to you, if you are ready to answer. Yeah. So first question would be, what would you see the future research directions in this topic?
Yes, we definitely need more research about if these prevention strategies actually work, and how good they work, and how work when you compare one prevention strategy to another. It's very difficult to do this research, but so far, yes, only few studies exist, and we need more about that.
Okay, then we have a very specific question. It's about a teenager in high school who experiences bullying because of her sexual orientation. How would you say it would be possible, or would be best to empower the school to deal with this problem?
Mm-hmm. I recommend to take a look at the Australians. They are way ahead with respect to this, and they introduced very early on, I think in the 90s already, they introduced mental health competency programs. So very basic primary prevention projects, which also included how to learn to deal with all sorts of diversities, not just sexual minorities or gender minorities, but also ethnic minorities. So it was tried to raise awareness for students very, very early on to come along well with each other. I think that's an excellent primary prevention possibility.
Could you say a little bit more about that, if you know what specifically it included?
I don't know how the actual interventions in the classroom, but the goal was really to educate young people that everybody is sort of different in some way. And if you, and I think it was about role play, about educating very young students what does LGBT plus mean, and to remove the stereotypes, to get in contact with each other. I think it was just a very basic intervention.
Okay. And I think it goes along with what you were presenting, that actually the better atmosphere around this, on community level, on a society level, then the better outcomes in terms of mental health and suicidal behavior are for LGBT plus people. That's what I'm getting from your presentation.
Yes, and perhaps I would like to add, if yes, that's true, and I think it's important when bullying happens, then such primary prevention is not sufficient. Here, it's really important that the leading people in the school are making very clear statements. In my experience, often when something happens in schools, the whole school organization is first faced with this problem. So there's a lot of dynamics going on in the school. How should we deal with the issue? Is the head of the department, does he or she knows about LGBTI issues? And it's so important that schools get prepared before these things happen. Like for suicide prevention, schools are completely overwhelmed when a suicide attempt happens in school, or a suicide, and there is a lot of chaos and dynamics, and it's always better to be prepared beforehand.
Yeah. And I'm just thinking, bullying, any kind of bullying is very painful for the one who experiences the bullying. But would you say that bullying with regards of sexual orientation or sexual identity could be even more
Yes.
painful? Why you say so?
Yes, and there are studies that can show that. So bullying because of being LGBT plus, or because of assuming somebody is LGBT plus, is more harmful than other types of bullying. There are really good studies on that this type of bullying is most strongly associated with suicide risk than compared to other forms of bullying. And I don't know why this is so, but perhaps gender role conformity is such a crucial feature of your identity that being violated in this is very strongly linked to self-esteem problems.
Okay, that makes sense, of course. One more question, and I encourage participants to write us more questions. We have some time left for a discussion. So the last question about your presentation that I have so far, maybe we'll get some more. It's about ICD-10 diagnosis, which is ICD-10 code 64, which is gender identity disorders. The question is very general. How do you see this diagnosis? And I think it's especially maybe you could comment that in context of changes in ICD-11.
Yes, the ICD-10 is hopelessly outdated, and I don't know if you know that, but the ICD-11 is already existing online in English, and it should be out already. But it's always such a challenge to get the diagnosis finished, so it's delayed year in year. But then you will see that the transgender, it's not gender dysphoria, it will be an extra section. It will be declared not as diagnosis. So it will be moved out of the mental health diagnosis, but it's still included in the ICD-11. to make access to healthcare possible for trans individuals.
Yeah.
This has already been done in the DSM diagnosis manual from the United States, and the ICD actually follows these DSM way.
Yeah, I'll just make a note for Lithuanian viewers and listeners that ICD is Tarptautinė ligų klasifikacija, and we have now Tarptautinė ligų klasifikacija version 10, 10th versija, and we are switching, I think, very soon to this ICD 11. And as you said, in ICD 11, I think it's called gender incongruence. Yes, incongruence, and it's moved from mental health problems to sexual health issues. So I want to hear your opinion on that. Do you think it's important to have sexual gender incongruence, not in the mental health section, but in sexual health issues? Why it could be important, this move?
Well, I think it's important because I don't think it's a mental health problem. It's not a mental health diagnosis. So this is what the activists are correctly fighting for years. Same as for homosexuality. Being gay or lesbian is it's simply not a mental health diagnosis. It's not a disorder. And so it was really a milestone when the WHO actually informed all over the world that LGBT plus is not a mental disorder. So it's really important to move it out of this section. The only reason why it's still there in the manual at all is, as I said, to make it possible for trans individuals to get gender affirmative health care, also medical care.
Mm-hmm. Okay, we have one more question. How do you see the broader role of mental health professionals, what they could do to help LGBT plus people in regards of their mental health, in regards of their suicide prevention? What would be the broader role of psychologists, mental health professionals, not only working with the individual client, but more broadly?
Well, I think it's important to really point out that being LGBT plus is not a mental health disorder. So it's a normal variation of sexuality or gender identities. And of course, if a mental health professional has this very clear position, this will be important for education of the general public. I think that's really important. And I think also that we have some kind of responsibility as mental health professionals to ally with all sorts of minorities. So I think that's perhaps also a responsibility that we have as professionals to be allies to those who perhaps need empowerment.
Okay, just for the sake of discussion, I personally, I totally agree with you. On the other hand, sometimes I hear from people, but shouldn't be mental health professional more neutral? Do not take sides, and so on. What would you say for that? Like it's more like political agenda, not.
What do you mean by taking sides?
Some people think that if mental health professionals support like LGBT plus people, it's like they are not neutral in their role. That's basically it.
It's a difficult question. I have to agree. It reminds me of the current discussion on the climate change, where some psychotherapies in Germany connect to make an organization to fight for improvement of the climate, that we can avoid the climate catastrophe. So I think it's an ethical question. And personally, I do think that in the mental health field, that we should ally with minorities. But of course, perhaps that's just my personal opinion.
Yeah.
On the when I talk as a scientist here, I think it's important to not be politically motivated, to let the data speak. Because this is can of course be used by people who are very homophobic or transphobic to say, oh, you look at those scientists, they take sides, they are not objective. Here, when I speak as a scientist, I really would welcome a very neutral way of thinking about the issue.
If it's possible, because I think it's so much finding around this topic. It's yeah, but anyway, as you said, probably it's not probably, but it's definitely it's not only about LGBT plus issues, but you know, supporting minorities is very important, because we know as professionals that it's a real impact for to mental health. You know, if you are a minority, and especially if you are discriminated as a minority. Okay, we some more specific people, specific questions that we have. So a very specific one. Somebody asks, I work with a 13 years old transgender person, teenager. How to help his parent, who is categorically not accepting that the person could be transgender? Very clinical question, very specific.
Yes, you know, Paulius, we talked about that when you introduced me for this talk. I'm not working with trans kids in my clinic, so I really lack experience here. But I think it has to be acknowledged that parents who find out that their kid is trans, they have to go through a very challenging time, and I think it needs time. And you can't just make a shortcut here. I think these parents need time. They need support. The recommendation from the Lead with Love project that I mentioned is to really recommend the parents that please don't do this struggle with your offspring. Get your support, express your negative opportunities and your transphobia. You can express this, but please avoid expressing it to the child. That is so injuring for young trans people. So this is what young trans people never forget. And as I said, when you experience homophobia or transphobia directly from your parent, this is really something that can be so damaging. So the recommendation for parents who are struggling is to find support, restrain from being hostile towards your child, even if you, and it's okay that you struggle. So
yeah,
just don't talk, just don't downplay this struggle, but don't do it with your child. Get extra support.
Yeah, I think I like this. You acknowledging that it's really a struggle for a parent, you know, to accept that it's a process, and that probably parents need help from us as mental health professionals. But as you say, this if they support the children, it could be tremendous help for them, as you showed the data of the studies show. Yeah. But if they don't support, it could be a really damaging effect. Okay, I think we could move towards the end, but I also want to ask you one final question, and it's actually not related to the topic that we were speaking now, but I just noticed on the Twitter that you just recently published a very interesting study about suicide on different time of the year. And as we approach Christmas and New Year period, so you know, there is a lot of, as you wrote, there is a lot of myth around this, that maybe people kill more themselves during the Christmas period and so on. So what the actual data shows, what the data says about this?
Yes, thanks for that question. Very much like to answer that because I do suicide prevention trainings, and I'm always faced with the problem or with the myth that people think suicide risk peaks on Christmas, and actually the contrary is the case, at least in most countries that I know of. So the suicide risk is actually declining these days in Advent, and reaches a very low on Christmas. And then the risk remains low until the New Year's Day. But on New Year's Day, you have really a peak, and it goes back to the yearly average. So overall, the Christmas time, despite being a very dark and cold time, at least in our countries in Europe, is associated with a lower risk. And the explanation is that perhaps it's that there's more social connection towards Christmas. There's more people look for other people who don't have families, so there's more social connectedness perhaps, but then this all ends after Christmas. And some explain this by the broken promise effect. So you have a very positive outlook towards Christmas, and then it arrives, and again, as we all know, it's not that good as we expected it, and then a whole new year starts, and you drink perhaps on New Year's Day, and here you have the increased risk. So that's clinically relevant. So take your move the attention for people at risk for suicide, not so much to Christmas time, but afterwards.
Okay. Thank you very much for this and for all the presentation and all the answers you gave to our participants. So thank you so much.
Thank you.
We have a safe lockdown in Austria, and I hope it's not too long and we are finally done with this pandemic soon.
Thanks, Paulius. Bye.
Bye-bye.